You are welcome on the stage. And today's last session's last talk. Thank you.
Principles of ATT. Dr. Deepak Shukla, Advance in TB Treatment and Diagnosis.
Sir, my topic is changed. Actually, it is very difficult after Dr. Amitesh sir topic. People are talking about artificial intelligence and very high-tech modalities for treating neurosurgery and neural diseases. And as science is developing, but still I am with the tuberculosis as this is very important topic. And as you said, Samik sir, it is last but not least in India. So these are the principles of ATT. I will discuss about the principle of ATT because all the guidelines which are presently running or will come to us, they are depending upon these principles. So I will conclude my topic very fast. So this is the history and evaluation of ATT. We can see the sanatorium era, standard long-term treatment, and then DOTS and current treatment policies. So natural outcome of the tuberculosis, when the patient was in sanatorium in UK, this study was done in 1947. Still we are seeing the patient who don't know that they are having that tuberculosis, but still their x-rays showing the patch at right upper lobe or lower lobe. So it is the study which is done in 1947, where sputum positive TB patients were taken and the chemotherapy was not given to these patients. And after 4 years, 55% of the patient died, 25% patient are having remission, and 20% remain chronic cases. So these are the drugs which are presently we are dealing with. The classification of ATT we all know: bactericidal, bacteriostatic, and WHO grouping, current classification. All these bactericidal drugs. This is the WHO grouping of ATTs. Current classification is first line drugs, that is HERZ, and used in the treatment of drug resistance, it is second line treatment. So this is the most important slide of my presentation, the principle of ATT. So when we are giving a patient with anti-tubercular treatment, we have to think about these points before giving or prescribing the ATTs. The multiple drugs, preferably more bactericidal drugs, should be there in prescription. So all the guidelines which are having, they are more four or three drugs, and majorly we are taking the bactericidal drugs. So, and the dose of the drug should be single. The drugs should be taken at morning or evening, but taken once in a day. And together, all the drugs to be taken together, because we need a single peak. If we send it is like commando operation. We are sending one commandos morning, one evening, one afternoon. So operation is going to fail. But if we give all the drugs at single dose, the TB will be treated. The adequate dose as per weight to be given to the patient. Sometimes we think that patient will develop jaundice, hepatitis, AKI, whatever is there. We have to give adequate dose as per weight. Education duration. So there are multiple type of tuberculosis. I choose this topic because it involve all the type of branches, like if you are also having neurological tuberculosis, and cardiologists are having cardiopericardial effusion and other. So adequate duration of the ATTs is very important. We are thinking that 6-month course is enough to the patient, but yes, the patient with tuberculosis who is coming first time to me, I used to give ATTs for 9 months. probably 9 months. The fixed timing and with coincide peak level. So you can see, as I told, that it is like commando operation. So fixed dosing should be there, fixed timing should be there, and coinciding peak level should be there. Never add single drug to a failing regimen. If the treatment is going to fail and we have to undergo for sensitivity test, if one drug is failing for the treatment, so we have to start another 4 drugs which are bactericidal and they are sensitive for the tuberculosis. Avoid drug with the cross resistance in the regimen, and preferably and if tolerated, the higher dose should be given to the patient. It means if the isoniazid can be given 3 to 5 milligram per kg body weight, we have to give 5 milligram per kg body weight. If the rifampicin can be given 8 to 10 milligram, we have to give 10 milligram per kg body weight. So this is the treatment principles, and the basis of ATTs are, we are dealing with 4 types of bacteria. 4 types of, one is rapidly grower, intermittently growing, slow growing, and dormant type of bacteria. We don't have any drugs to kill these dormant type of bacteria which make remission of the patient, remission for the tuberculosis. So slow growing intracellular acidic pH pyrazinamide is very important drug in initial therapy because isoniazid can penetrate the acidic medium, and initial 3 months is very important. That's why it is given to the initial patient initial 3 months. If we are not giving pyrazinamide, the therapy would increase for 6 months to 1 year. That's why in initial cases, patient should be introduced with pyrazinamide to slow growing and acidic medium pH. Then rifampicin. Rifampicin is very, बोलते हैं पिक्चर का हीरो है ये. क्यों? क्योंकि ये एक्स्ट्रा सेलुलर एंड न्यूट्रल पीएच एक्ट, रैपिडली ग्रोइंग, इट विल किल द रैपिडली ग्रोइंग एक्स्ट्रा सेलुलर also, and it will also kill the intermittently growing and semi-dormant extracellular neutral pH. So rifampicin is a drug which is the hero of picture. If the resistance with rifampicin is there, then we can say that patient is also multi-drug resistant patient. Only rifampicin resistant can say that. So these are the basis of ATTs, and current classification of TB cases is drug sensitive TB and drug resistant TB. And drug resistant TB is further divided in 5 types. So I will not discuss the treatment for the tuberculosis. The modification of ATT regime in a special situation can be done in pregnancy, hepatic renal impairment, seizure disorder, and people living with HIV and AIDS. Here I am completing the topic. Thank you very much. And as Behrani sir is there in the chair, so I expect some question from him, or if anyone asks, so I left with 2 minutes more. So you can ask question too.
Can I
Yes, sir.
ask a question to you?
Yes, sir, please.
Deepak, is the anti-tubercular regimen different from the routine regime for pulmonary cox vis-a-vis skeletal tuberculosis, spot spine?
Yes, sir.
Like, we generally tend to prolong the treatment to 9 months,
Yes.
or sometimes 10 months. So, but of course, initially it was said that you have to give it for 12 months to a year.
Yes.
But of course, even now, I don't know, there are conflicting ideas that you should stop the treatment at 6 months, even whether it's skeletal tuberculosis or not. So I want your view on that.
Sir, there are actually tuberculosis is a disease where all the drugs should be penetrated to that side only. So in bone tuberculosis there is less penetration with the drugs. So it's in bone TB we have to give more than 1 month or 1.5 years. I have some patients with pot spine. I am giving them they are coming to me after 6 months. कि पेशेंट को दिया 6 महीने लेकिन उसके बाद फिर से रिलैप्स हुआ और फिर लेटर ऑन हम आज दे रहे हैं और पेशेंट इज स्टिल टेकिंग द एटीटी, सी इज वेल टॉलरेटिंग टू एटीटी एंड अभी भी उसको बेल्ट लगाती है, सी इज कंफर्टेबल और अभी तो बेल्ट भी हट गया सर, स्टिल माई एटीटी इज कंटिन्यू, 2 years का मैंने उसका कोर्स डिसाइड किया हुआ है एंड इट ऑल डिपेंड अपॉन द ESR वैल्यू. If the ESR is decreasing, so then you can stop or hold the ATT. Sir.
Brain TB and CKD patients, they require different.
Yes, sir. Sir, brain TB and CKD patient में
Regime different हो जाती है ना?
Sir, we can see the modification can be done in the hepatic and AKI patient. As you all, मैं आपके साथ कई बार OPD में पेशेंट देखता था तो आप बताते थे कि अगर AKI का पेशेंट है तो उसका ड्रग बाहर निकलता ही नहीं है, तो वो बाहर वापस से रन करता है. तो उस ऐसे पेशेंट में इनिशियली इट वाज सेड दैट कि आपको ATT का कुछ E और Z, इथेम्ब्यूटोल और पायरेजिनामाइड डोज शुड बी रिड्यूस टू हाफ, जो हम दे रहे हैं उससे हाफ करना है और डेली देना है. बट लेटर ऑन रेजिम वाज चेंज्ड and it was saying that ethambutol should be continued in same dose which is required to the patient as I said, but ethambutol and pyrazinamide should be continued for alternate days throughout the treatments. Yeah, sir, बात यही हुई, but newer guidelines are saying like this same.
में भी हम लोग पहले 1.5 साल तक देते थे, फिर सरकार देती नहीं है, 6 महीने बाद बंद कर देती है.
नो सर, ये गलत तरीका है. सरकार इज स्टिल गिविंग, इफ यू आर प्रिस्क्राइबिंग द पेशेंट, आई वाज सेइंग दैट इफ पेशेंट इज एडल्ट यू हैव टू गिव 6 to 9 months, और इफ यू आर राइटिंग नोबडी कैन क्रॉस योर प्रिस्क्रिप्शन.
टीबी में
यस सर.
ट्यूबरक्लोसिस,
Miliary tuberculosis is a type of pulmonary tuberculosis, but it is different type because it is blood-borne. So it is in all over the lung. All over the lung there is shadow. Miliary tuberculosis is also treated like pulmonary tuberculosis only because the penetration of drug is same in the lungs. So it should not be increased more than 9 months.
So in standard pulmonary tuberculosis, how many months?
In standard pulmonary tuberculosis, 6 to 9 months. It depends upon the physician and the response of the patient. If patient is well tolerating, nothing is there, go ahead for 3 more months. So the relapse chances is very less. Okay. In adult patient, I used to give 9 months. In adolescent or who are having कि अब बंद करो बॉस, अब हो गया मेरा, तो उसको.
Is it still like for first 2 months you give 4 drugs, then you come down?
No sir, actually the therapy is, if you are planning to give the drug, I said pyrazinamide is very important drug. If you are giving pulmonary tuberculosis or purulent cases, so pyrazinamide is to be given for 3 months initially and 6 months for HRE. If you are giving and trying for the 9 months, sorry. So if you are deciding the patient को हम 9 month देंगे तो 3 months ये और 6 month CP.
4 drugs चलना है 3 महीने minimum.
Yes sir, yes sir. Sir, POTS fine. I said, sir, in every type of purulent cases, we have to give. It is very necessary to give, sir. If patient is tolerating, आँख बंद करके देना चाहिए. So, it is very important topic, but very least discussed. That's why
Dr. Deepak Shukla, in the interest of time, we close the session. We thank you, Lord,
sir,
for
thank you
giving
so
us
much.
insight
Thank you, sir.
and enlightening us. Thanks a lot.
I would call upon Dr. Abhishek Srivastav, Dr. Amitesh Dubey is here, and Deepak of course is here. Please collect your awards. Mirani sir, aye, please. Deepak. I think we come to a close of the session on day 1, and we'll be having our award ceremony and the cultural events soon. Thank you all. See you soon.